So welcome to this chill out sessions with the Master Guru. We're going to summarize some important pearls in internal medicine, and we're going to have a hematology, blitz. We have a separate session for immunology. We're going to focus on this segment on hematology. These are the references which I'm using: Harrison's, Guyton Medical Physiology, and Robbins' Pathologic Basis of Disease. So let's focus on the must-know pearls of hematology. So first, during development, from the embryo until adulthood, there are different sites for hematopoiesis. During embryonic life, the yolk sac is the main site of hematopoiesis. Mid-trimester gestation, it's now the fetal liver. And during late gestation, until an individual is 5 years old, it is now the bone marrow. So when does the bone marrow become a site for hematopoiesis? Is it before birth or is it after birth? When does it become the major site of hematopoiesis? It becomes the major site of hematopoiesis from the late gestation until after birth. So from 5 to 20 years old, the humerus and the tibia, we're talking about long bones, are the main sites of hematopoiesis. After 20 years old, so this is now adulthood, the main sites of hematopoiesis would be the flat bones, the flat membranous bones, such as the ribs, the pelvis, the vertebrae, and the sternum. So please review the sites for hematopoiesis. Now, what is the strongest stimulus for erythropoietin production? What is the strongest stimulus for erythropoietin production? Okay, it is hypoxia. And what are the specific cells in the kidney that produces this hormone, erythropoietin? What specific cells in the kidney will produce erythropoietin? It is the peritubular cells of the kidney. Okay. Now, what are the regulators for erythropoiesis? So these are the factors that would regulate erythropoiesis. So number one, we have the CSF, okay, the granulocyte colony stimulating factor, or the GCSF. Then we have the interleukins. Then we have erythropoietin, and of course we have thrombopoietin. So the GCSF, it's usually referred to as the granulocyte colony stimulating factor. Interleukins play a very important role. Now, what interleukins play a role in erythropoiesis? Which specific interleukins? Interleukin, what number? What interleukins? Give me at least 2 interleukins that plays a very important role in erythropoiesis. Interleukin 3 is 1, okay? Then we have interleukin 1, okay? 1, 3, okay? They would play a very important role. Now, what is the key to erythropoietin gene regulation? What gene? The key to erythropoietin gene regulation. Okay, this is what we call the HIF, the HIF1 alpha. This stands for hypoxia inducible factor 1 alpha. Hypoxia inducible factor, or HIF1 alpha. This is the key to erythropoietin gene regulation. Now, question. Let me give you a case of someone who lives, let's say he lives 5,500 meters, or feet rather, above sea level. He's lived there for about 3 months. His hemoglobin levels is 53. Okay, no, that's hematocrit. My bad. That is the hematocrit. That would be crazy if the hemoglobin was 53. Hematocrit is 53. What condition does this patient have? Lives basically in a high altitude where there is hypoxia. So this is polycythemia vera. Now question, what is the most common gene mutation associated with polycythemia vera? Okay, perfect. This is JAK2, a JAK2 mutation. Whenever you encounter the condition polycythemia vera. Gene mutations, gene regulation for erythropoietin, that's HIF1 alpha. Okay, now let's go over the must-know hemoglobin reactions. Hemoglobin can combine with certain substances and it forms a complex. So let's begin with the first. Okay, what hemoglobin reaction is this? The normal oxygen-carrying form of hemoglobin in which iron is in the reduced state, or what we call the ferrous state. Always remember, we do not want hemoglobin, the iron in hemoglobin, to be in a ferric state. We want it to be in the reduced ferrous state. So what form of hemoglobin is this? What form of hemoglobin is this? Okay, this is, of course, oxyhemoglobin. The normal oxygen carrying form of hemoglobin is oxyhemoglobin. So this is when oxygen binds with hemoglobin. What complex is formed? It is oxyhemoglobin. So here you have hemoglobin binding with oxygen. This will form oxyhemoglobin. And this is responsible for the bright red color, okay, of arterial blood. What is responsible for the bluish color of venous blood? What is responsible for the bluish or purplish color of venous blood? It is deoxyhemoglobin. Okay, deoxyhemoglobin. So oxyhemoglobin, this is the normal oxygen carrying form of hemoglobin. What about this? The complex formed within the red blood cells when hemoglobin is exposed to carbon monoxide. What is this reaction or form of hemoglobin? Carbon monoxide plus hemoglobin. This is carboxyhemoglobin. Again, this is carboxyhemoglobin. Now, when oxygen, okay, binds with hemoglobin, that is oxyhemoglobin. When hemoglobin binds with carbon monoxide, this forms carboxyhemoglobin. Now, between oxygen and carbon monoxide, which has a higher affinity? Okay, carbon monoxide has a higher affinity. Okay, it has a higher affinity. Okay, 200 times higher affinity. And if someone has carboxyhemoglobin in their system, and let's say they die of carbon monoxide poisoning, what is the description of the skin and the mucosa? The skin and the mucosa. Okay, the skin and the mucosa will now appear to have the cherry red color. Okay, now some pearls, which you have to bring with you to any standard exam. The electron transport chain, also known as the respiratory chain, occurs in the inner mitochondrial membrane. It has 5 complexes. Complex 4 is the enzyme cytochrome oxidase. What are the 2 substances that inhibits cytochrome oxidase or complex 4? We have carbon monoxide and we have cyanide. Carbon monoxide and cyanide. So always remember that. Okay, so this is the cherry red mucosa. So carboxyhemoglobin, bright red. Okay, that's not carboxy, that's oxy. Okay, this is the carboxy. This is oxyhemoglobin, bright red. Carboxyhemoglobin, that's the carbon monoxide, is the cherry red mucosa of the skin. What you see here is carbon monoxide lividity. So these 2 individuals are dead. Okay. Now, what do we call the non-functional form of hemoglobin in which ferrous iron is oxidized to ferric? Okay, this is basically a non-functional form of hemoglobin. This is methemoglobin. Okay, a non-functional form of hemoglobin in which the ferrous iron is oxidized. The key word here is oxidation of iron or oxidation of ferrous iron to become ferric. Okay, this is now methemoglobin. Now, where is the most common site of iron absorption? The most common site of iron absorption, majority is in the duodenum. Okay, the rest is going to be in the proximal small intestines. So partly jejunum. It's basically duodenum and jejunum. So any surgeries that removes the duodenum or the jejunum would lead to iron absorption problems, iron deficiency. And the most common anemia worldwide, the most common nutritional anemia, this is iron deficiency anemia, commonly known as IDA. Okay, now, just some basics. What is the storage form of iron? The storage form of iron is ferritin. The transport form of iron is transferrin. Okay, storage form of iron is ferritin. Transferrin is the transport form. So as you can see here, oxidation of ferrous would become ferric. Okay, that is the iron core. Now, this is a table lifted from Mama Harrison's, our Bible in Internal Medicine. What is the normal iron stores of an adult male? We're always going to use the adult male, okay, because there are lesser iron stores in the female, because the female has menstruation. They have monthly losses of iron. So what is the normal iron stores? I want this to come from you. What is the normal iron stores of an adult male? It is 600 to 1,000. Okay, 600 to 1,000. Okay, 600 to 1,000. That is the iron stores of an adult male. Now, etiologies causing iron deficiency anemia. There are three categories. One, if there's an increased demand for iron. Number two, if there's an increased loss of iron. Number three, when there is decreased intake or decreased absorption. Pay attention to the conditions which increases demand. So we have erythropoietin therapy, pregnancy, and rapid growth during infancy and adolescence. We have hypercatabolic states. Now, increased iron loss is associated with chronic blood loss, like when there's peptic ulcer disease. Okay, that is the most common cause of upper GI bleeding, or when there is significant lower GI bleeding. Okay, menstruation, acute blood loss, blood donation, and polycythemic patients who undergo phlebotomy. So please take note of that. Now, question. If there is iron deficiency anemia, what is the classic peripheral smear? Okay, iron deficiency anemia. What is the classic peripheral smear? So we have cytic, then we have chromic. Okay, what would it be? It would be microcytic, which means the MCV is how much? If this is microcytic, okay, that means the MCV is less than 80. And it is hypochromic. So microcytic hypochromic anemia. Now let me give you a patient on hemodialysis. Someone diagnosed with CKD. What is the peripheral smear of a patient who has anemia of chronic disease secondary to chronic kidney disease? It will be normocytic, normochromic. Okay, normocytic, normochromic. So please remember that. Okay. Now, we mentioned this earlier, polycythemia vera and a mutation in JAK2. I just want everyone to remember, okay, the kidney produces, particularly the peritubular cells produces erythropoietin. Erythropoietin would stimulate the bone marrow to produce RBCs. Now, in the hepatocytes, in the liver cells, there is a very important substance or protein which in inflammatory states, okay, would suppress iron absorption and iron release. What is that protein? It is hepcidin. Okay, so here, what protein made by the liver and is increased in inflammation would suppress iron absorption and suppress iron release? This is hepcidin, the protein that suppresses iron absorption and iron release. So this will explain anemia of chronic disease, most especially if it's associated with inflammation. Now, conditions such as primary myelofibrosis or PMF. This is characterized by the following. Number one is fibrosis of the bone marrow. When the bone marrow is affected by myelofibrosis. It is now hypocellular, not hyper. It will be replaced by fat or adipose. So you have a hypocellular, fat-filled bone marrow. Can you give me another condition that would present with the same bone marrow finding? Hypocellular, fat-filled bone marrow. What type of anemia? Okay, perfect. It is aplastic anemia. And what is that famous virus which causes aplastic anemia and pure red cell aplasia? Okay, this is parvovirus B19. This specific virus affects the erythroid precursors. So as a result of this bone marrow fibrosis, there's going to be aplastic anemia, there's going to be splenomegaly, and the RBC will be nucleated, which is abnormal because the adult RBC is supposed to have no nucleus. It is the reticulocyte or the immature form of the RBC which has a nucleus. And the shape of the RBCs will now be the teardrop. Okay, so this is primary myelofibrosis. Nucleated RBCs, teardrop RBCs. Now, in bone marrow aplasia, can you give me the antibiotic which is notorious for causing bone marrow aplasia? What antibiotic? Okay, it's chloramphenicol. So aside from causing gray baby syndrome, where there is a problem with the enzyme glucuronyl transferase, chloramphenicol can cause bone marrow aplasia. It can cause aplastic anemia. Now, what chemical is notorious for causing bone marrow aplasia? What chemical? Okay, perfect. It is benzene and chloramphenicol, as well as alcohol. Okay, benzene, alcohol, which is ethanol, can cause bone marrow aplasia. Parvovirus B19 specifically causes pure red cell aplasia. Okay, so this is the classic description of bone marrow aplasia. So there is replacement of the bone marrow cells with fat. Okay, so it's replaced by adipose tissue. Now, what about sickle cell anemia? What are the pearls about sickle cell anemia? What type of mutation is sickle cell anemia? What type of mutation? This is a missense mutation. And what are the 2 amino acids that are substituted? What 2 amino acids are substituted? It is valine and it is glutamic acid, particularly at position 6 of the beta-globin chain. Now, what race is affected most by sickle cell anemia? It's usually African American. What type of mutation? It's a missense mutation. So remember, in a missense mutation, when there is a substitution of amino acids, this leads to a structural change. And as a result of the structural change, there will be a morphologic change. Okay, so this is a classic point mutation, missense or point mutation. Now, one of the classic fears we have in sickle cell is the famous vaso-occlusive crisis. So always remember, hemoglobin, okay, will undergo polymerization. It's actually polymerization of deoxyhemoglobin. And this makes the RBC what? Does it make the RBC more flexible or does it make it sticky? Okay, the key word is the sticky. Okay, so this leads to a vaso-occlusive crisis, which can cause several manifestations like stroke, bone pain, back pain, abdominal pain, chest pain, headaches. This is occlusive, vaso-occlusive crisis. Yes, sickle cell anemia is notorious for causing osteomyelitis, particularly by what organism? So don't forget, Salmonella, ella is sickle cella. Okay, Salmonella causes osteomyelitis in sickle cella. Okay, now this is what I want everyone to remember. Several drugs to treat sickle cell. I only want you to remember hydroxyurea. What is the mechanism of hydroxyurea? It will induce hemoglobin F production. Question: which has higher affinity for oxygen? Is it fetal hemoglobin, that's hemoglobin F, or is it hemoglobin S? Which has higher affinity to oxygen? It is fetal hemoglobin. So that is what the drug hydroxyurea does. Okay, so winding up this coaching, let's mention the diseases that affects the globin chain. Always remember the adult hemoglobin, that's hemoglobin A1, that has 2 alpha chains and it has 2 beta chains. Any disease that affects these globin chains is called a thalassemia. Now, don't forget hemoglobin F, that's fetal hemoglobin. It has 2 alpha, it has 2 gamma. Okay, so again, adult hemoglobin, 2 alpha, 2 delta. Fetal hemoglobin, 2 alpha, 2 gamma. So chromosome, alpha versus beta thalassemia. What chromosome number is involved in alpha thalassemia? And what chromosome number is involved in beta thalassemia? So always remember, alpha thalassemia is chromosome 16. Beta thalassemia is chromosome 11. Okay, so please memorize this. And what is the classic features, the facial features of thalassemia in general? What is the facies? Okay, so this is how they're gonna look. They have the chipmunk facies. Okay, the chipmunk facies. And what is the etiology? What is the pathogenesis behind the chipmunks? Look at the forehead. Okay, that's a frontal bossing. Okay, there is expansion of the bone marrow. The bone expands as a result of extramedullary hematopoiesis. So particularly the bones of the forehead, the frontal bone, and the zygomatic bone. Okay, that's extramedullary hematopoiesis. Now, what is the classic radiographic feature of sickle cell anemia and thalassemia? As you can see, this is the crew-cut appearance, which is also mentioned in the textbook as the hair on ends appearance. Okay, we have the crew-cut appearance or the hair on ends appearance. Now, which of the alpha thalassemias is fatal in utero? Which of the alpha thalassemias is fatal in utero? This is what we call hemoglobin BARTs. How many gamma chains are in hemoglobin BARTs? There are 4. So this is what we call the tetramers of gamma chains. And this is associated with a condition that leads to stillbirth or stillborn, that is hydrops fetalis. This is the most fatal form of alpha thalassemia. Okay. Now, lastly, we have this hereditary condition known as HS or hereditary spherocytosis. Always remember the RBC has extrinsic proteins. Two of the most important extrinsic proteins is spectrin and ankyrin. Okay, question. What will happen to the RBC if it's shaped like a spear, so a spherocyte? What will happen to that RBC as it squeezes through the splenic sinusoids? Okay, it will hemolyze. It will rupture because it is more fragile than the standard or normal biconcave shape. Okay, so it is prone to hemolysis. So don't forget this. Majority of hereditary spherocytosis is autosomal dominant. It's AD. 3/4, 75% is going to be autosomal dominant. The most common cause of autosomal dominant hereditary spherocytosis is a mutation in ankyrin. The most common protein deficient in hereditary spherocytosis is spectrin. So listen to this well, because this is lifted verbatim from the mother book. The most common cause of autosomal dominant hereditary spherocytosis is an ankyrin mutation. The most common protein deficient in hereditary spherocytosis is spectrin. Okay, so lastly, what is the diagnostic test for hereditary spherocytosis? What is the diagnostic test for hereditary spherocytosis? It is the osmotic fragility test. Okay, this is the diagnostic test of choice for hereditary spherocytosis. That is osmotic fragility test. So this is Doc Toom, your master guru. I hope you learned something. I hope you apply this not only to your exams, but you apply this to the bedside and the clinics, so you can be the best version of yourself to become the most competent and compassionate physician. So thank you for joining our chill out sessions. God bless and happy studying.